Okay, welcome everybody. Happy Friday. Welcome back to winter, I feel like. Geez. Okay. Enough of that. It will end sometime. So today we're going to cover urogenital tract infections. There are numerous organisms that we will talk about from things like a UTI, urinary tract infection, to STIs, sexually transmitted infections. There are a good handful of players as we move through here. And we've seen a couple instances like the neonatal gonorrhea. We saw some of that and some of the chlamydia with the eye infections. We've seen a little bit already, right? And I will mention at the start of this that there are definitely going to be a handful of images in here that are a bit graphic. So just be warned of that. I'm sure you already know, because I expect you've read every stinking chapter that we have covered, right? You must have. And it's right now, a week before we're covering the last material. You're like, wait a minute, there's a textbook? I know that's not true. As before I jump into this, not that there's a textbook, but I teach a biology class up by the biology building in the lecture center. And there is another biology class happening in the same building at the exact same time. I'm teaching 1100, the concepts biology for people that don't really want biology, right? And the other class is majors biology, 1102, people that want to do biology, some sort of biology. I have had multiple students contact me and they are like, I apologize, I have been in the wrong class. I should be in your class, but I've been going to this other class. I'm at, the first 2 weeks into the semester, I'm like, okay, that's okay. This person my last one, so 3 of them, my last one that contacted me, it was after midterms had already occurred, that he was like, I've been attending the wrong lectures. It's like this, tests are on Moodle. So he was doing really good on the tests, getting material that was probably a couple of extra steps above what he truly needed to dive into. I'm like, geez, maybe you ought to think about biology, right? All right, enough of that. Just saying, there's a textbook reminded me of people that were in the wrong class. I know sometimes those are nightmares people have. They're like, I wake up and realize it's finals week and I never even went to class. I didn't even remember I was enrolled in that class. Oops, right? That's not good. All right. And for those of you tuning in at home, you know you're supposed to be tuning in, right? Here you are. All right. Oh, and now we're closed captioning. Okay, so there are lots of different things that we could think about as some potentials for urinary tract infections. There are a number of them that we think of as potentially some normal flora elsewhere, maybe the GI tract lending to some of these opportunities. Oftentimes some common culprits for that. There are lots of different ways, and deep down, I will tell you, I have tried a couple of times to get to the details of what I'm truly looking at on this plate, because I don't get any of the actual specifics spelled out in the text as far as what it is. I searched up some stuff. I could see some similar plates, but nothing that actually spelled out exactly what I'm looking at. I know this has got to be some sort of selective and differential media. There are lots of things that pop into my mind. I know it's probably not the right thing, but I see this with like this blackish looking pigment, and I think hydrogen sulfide production, and then I think salmonella. I don't think that's what we're looking at all. Likely, who we're seeing is probably some Proteus. You maybe saw some Proteus. Not maybe, I'm pretty sure you saw some Proteus in the lab when you were doing some of the biochemical tests and you did the urease tests. I believe Proteus was the one that would have been urease positive and turned those little broths pink. And your other bacteria, probably E. coli, did nothing to it, right? And it still looked peach colored. And maybe, if I remember right, there's maybe some of those Proteus that can actually do some of that. So that maybe that's who it is without actually knowing the details and knowing what type of media it is, because I never actually saw what it is, but different. So you have all worked in the lab with inoculating loops, and you've all probably gone up to the bench and grabbed your loop. And every time you get a loop that's a little bit different, some of them are pretty good and nice circles, and some of them are bent, and you're like, who used this, right? It's all messed up, right? Different sizes and weird things. When we think about looking for a UTI, we're not going to use an inoculating loop like we have been working with in the lab, because that, who knows how much you're actually getting. And we would like to be able to be a little more quantitative with this. And so there are some like little plastic disposable loops with circles in there that are calibrated, oftentimes two-sided. One's got a bigger loop like you're pretty familiar with, and then the other side of the loop, the other loop on there, the other end, is very small, a little circle. And that's something that we would think about using to swab a plate or to streak a plate. Those little circles are a microliter. It's calibrated for that. So you know you put a finite amount of urine onto the plate, and then based off of counting up colonies, individual little bits. In this case, I don't think that's really what we're doing, because it's a big swath of stuff, but could be. If you see just a handful, you might think, well, that's maybe just some normal flora, not really much of an issue. But if there are numerous colonies, then we start thinking there's truly something going on. The ways we collect urine specimens also are varied. Oftentimes, what we collect is a midstream clean catch. So you start voiding urine after some cleansing to ensure we're not getting a bunch of endogenous organisms. We start urinating and then pass the cup midstream and only get that middle bit, not the first drops and not the last drops. There are other potentials where they want all of it, and they typically want the very first. Usually the first urination in the morning, you've got quite a big volume, and in turn, they collect all of it from first to last drop, and there's other things that they're doing with some of those things. Lots of other potentials when we think about urine samples to look at things and kind of gauge some potentials, some of it lending to the thoughts that maybe there is an infection happening. So a little bit of anatomy with this and potentials for organisms. We typically think that the urine should be sterile, but the potentials with UTIs lending up into the bladder or through the ureters up into the kidneys are some potentials. Just depends. So this image, I don't want to go into great detail, but we've got a cross section of our kidney, and we can see the glomerulus right within here. And we have, I just want to mention it as we're looking at it right here. We've talked about glomerular nephritis with issues with like post-streptococcal immune complex problems. And this is really where we see these issues, as we see the glomerulus getting targeted with these complexes, complement activity causing destruction, and ultimately impacting the entire function of the kidney, is really what's happening as we get right within that. So this is just showing the filtration of the blood and removing the wastes out through the urine, into the urine, out to the ureter and to the bladder. So potentials with this, as we think about urinary tract infections, we may think of sometimes potentials for the GI organisms to maybe lend to some of those problems. And in those circumstances, often it may be more common in females than males to see some of these UTIs and some of the normal flora of the GI tract being a contaminant. There are also potentials as we transition and shift gears to sexually transmitted infections to think about other potentials, and we will dive into that shortly. Truly lending to numerous different things. So I don't know if they still do this, but in A&P labs, they used to do some urinalysis where they would group students up and some would get just regular water, some would have some salt water, and others would have distilled water, and they drink stuff and measure amounts of urine that they're voiding. And they also did some of these dipsticks to kind of see some of the details about that. That might have been a completely different lab, but I feel like they were incorporated together. And I recall I was teaching one of the microbiology labs, but there were lots of students coming down the stairs to go to the restrooms because the A&P lab was right up above there. And they wanted, you know, multiple people all need to use the restroom. They're going all over. And I'm like, what are you doing? As they're carrying dipsticks and cups, right? I'm like, it's kind of weird, right? But also kind of interesting. So this gives you all sorts of details about specifics that might be within the urine, chemicals and proteins, cells, abnormal things. And this is kind of like some pH paper as we match it up as we move around the bottle to try to see where we fit. Gives us some details about potentials of maybe an infection or other situations. So Leptospira, this is a bacterium that we would, that we classify as a zoonotic disease. It's a bacterium that we can see in the urinary tract of lots of animals, and the potential for us to become infected by coming in contact with that is, I mean, really kind of depends on your activities and interactions with animals that may lend to a greater opportunity. It is a spirochete. And well, we'll see some more details with it as we wrap this up and see some table material. This makes me kind of curious if that's what we were maybe seeing on that plate before. But then I'm like, I don't think so, because this is an anaerobic organism. And I don't think that other plate, there wasn't any details about that, and it doesn't look like something that would have been cultivated like it. So these guys, the Uriplasma urolithicum, which also with a name like that makes me think these suckers would be urease positive if we did a urease test. But I think being anaerobic, you would have to manipulate that test to set the stage for it to actually be under those conditions. So this pointing to the organisms and then cellular debris, which is a lot all around. So as far as the urinary tract infections go, there are lots of players that lend to some of these potentials. So cystitis has a huge list of organisms. Some of these we think of as inhabitants of the GI tract, E. coli and Enterococcus, strep and These three definitely potentials to be there. Same with Staphylococcus saprophyticus. Klebsiella pneumoniae, probably not truly an inhabitant that we would think about of the GI tract, all right? So all sorts of issues, signs and symptoms, painful and problems, urinating, pus, blood, pain in the bladder. It's more common in females, and this is, again, shorter urethra and closer proximity to the GI tract that lends to contaminative problems, right? Non-transmissible, opportunistic, and again, the fecal bacteria is a potential with that. Handfuls of antimicrobials, and the dipstick we just saw a second ago would be a mechanism to detect some issues with that. Our little spirochete, the leptospirosis from Leptospira, like I said, is zoonotic. As we come in contact with urine or body fluids from those animals, fevers and headaches, chills and vomiting, diarrhea, all sorts of issues, liver damage, and potentials for meningitis, all sorts of things. I also feel like leptospirosis can infect the eye and cause issues with blindness. Pretty sure it's a culprit for that. Non-gonococcal urethritis. So this is basically urethritis that's not caused by gonorrhea. That's what we mean by that. Chlamydia, mycoplasma, a couple of them, and then our ureaplasma that we just saw can be mild to asymptomatic. That lends to some potential issues. If we do progress from mild to more severe, there can be some purulent discharge and dysuria as a result. So it is potential to be sexually transmitted, but it can also be transmitted to the child in transit through the birth canal. So a couple opportunities with that. Pleonephritis and glomerulonephritis. I mentioned the glomerulonephritis with those complexes. Here's our pyogenes with that, but E. coli, Proteus, and some Klebsiella, they fit into the category with this also, and this more infection, not immune complex, like we did with the nephritis. So all sorts of issues, signs, and symptoms with that. Okay, so shifting away from urinary tract to thinking more reproductive tract and potentials, there are numerous things that we will talk about, and it really kind of depends on circumstances with some, where we may think more common to see in females than in males. Oftentimes in females, it's more common to be symptomatic than when we think about some of these infections in males. Not that they aren't going to be symptomatic, but there are oftentimes circumstances where we see that being a little more of a situation. And in those circumstances, when we think of these as sexually transmitted infections, when individuals are asymptomatic, you don't know that that's going on in the first place. And that sets the stage for it to be shared, lending to bigger problems. So here we've got a vaginal smear, and we're looking at a couple of cells right here that are normal epithelial cells, and then down below we've got one that we call a clue cell. And this, technically, it's some epithelial cells, but they are covered in bacteria. And pretty sure Gardnerella vaginalis is the bacterium that gives us this result when we look at these smears. Almost positive. We'll get to the table of these guys shortly, and I will verify that, but I'm pretty sure that's who it is. So now for some of these images. This both, all three frames here are images of gonorrhea. So we've got some gonococcal discharge in both male and female, similar and different. All right. There is also maybe the potential for some other lesions going on. All right. And that's what it says right here. All right. Possibly some syphilis. We'll see some of that and some others here in just a second. All right. So oftentimes we see some purulent discharge. And with that, we could stain this stuff, this discharge. We could do some swabbing and under a gram stain, these bacteria, which is what we're looking at right here. This is a bunch. So this discharge would be full of white blood cells, and under a gram stain, which is what we have done, these guys are going to appear technically gram negative. They don't have a cell wall, right? It's just a membrane. So the neutrophils, which it looks like all of these guys are, the crystal violet would stain it, and then you decolorize it with alcohol, and then the safranin would make them look negative. All right. That's a sidebar. What we're truly looking at is these little clusters of gram negative bacteria surrounded by neutrophils that are truly trying to kill all of these bacteria. That's what a neutrophil's job really would be. All right. Gonorrhea is a gram negative diplococci. So two cocci oftentimes seen linked together. They sometimes describe it as a kidney bean appearance, kind of curved the littlest bit. That's the idea with it. Chlamydia is the next bacteria we want to look at. Chlamydia trachomatis. Chlamydia is an kind of odd bacterium in the fact that these guys we call obligate intracellular parasites. You can't grow them just on normal culture media. They won't grow. They need to infect living cells. So you need a cell culture, human cells, to allow for them to be cultivated in the first place. And that's what we're looking at in this first image. So these McCoy cells, it's a monolayer, so a single layer of these cells that in turn serve as the culture media for the chlamydia. And here we can see a couple of few inclusion bodies where the chlamydial organisms have got in and infected those McCoy cells and showing a positive reaction. So there's here we could see lymphogranuloma venereum. These buboes that we see here are the result of the chlamydial infection. So it's, you know, swollen lymph nodes, but it's the result of these organisms. So here, a couple of images of syphilis. There are multiple stages of syphilis: primary, secondary, and tertiary syphilis. The first image right here is primary, where we see this ulcerated sore. It's a hard chancre that's caused by Treponema pallidum. That's the bacterium that causes syphilis. And with these, although this ulcer looks as if it should, you would imagine, be painful, apparently painless, right? Which I find interesting. There is another one that causes ulcers that are the opposite. They are very painful, and it's a Haemophilus that does that. We'll see it in a second. All right. So hard chancre caused by syphilis that's painless. The secondary syphilis is a rash that results. We can see this on the hands, potentially elsewhere, but often this is where we see the involvement, and it may be transferred from contact with that. Tertiary syphilis is as we have basically gone systemic. We see lesions called bumas tissue lesions, but there are potential for lesions in the bone. Central nervous system involvement is a possibility. And we can see all sorts of issues with this, all right, as it progresses and we start thinking central nervous system involvement and potentially causing the demise of some of these individuals. As we've got this on here and the central nervous system stuff, they're way back in the day at the very start of the 1900s. And right now, I don't remember the name, matters not. A physician used malaria and the high fevers that you get from malaria. They infected a patient with syphilis with malaria to treat the tertiary form of his syphilis and basically try to cook it out of them with those high fevers, which I think is terrifying that you would want to deliberately infect yourself with malaria, but you're also in the grips of death from syphilis. So maybe at that point, it doesn't really matter. I don't know. And in turn, it was apparently an effective treatment. But then you wonder, at what cost? So treponema is another spirochete, as we see this dark field image of it, and then a silver stain. There are other potentials where we can use some antibodies that can link up to the bacterium, and then you can get some fluorescence, and we can use that for some identification because the antibody would be specific to that organism. Here is the Haemophilus. So the chancre on this guy is painful as opposed to the syphilis lesion, painless, all right? And we call this chancroid. Haemophilus in our gram stain over here is a gram-negative rod-shaped bacterium and cultured apparently with some rabbit blood. Interesting. It makes me wonder, we saw Haemophilus growing on the chocolate agar before, and I mentioned Haemophilus needing the lysed red blood cells. It makes me wonder, is this cooked? Potentially lending to it being able to get cultivated. I don't know. Okay, so a quick list of some of these players. Bacterial vaginosis, those clue cells, like I said, the Gardnerella vaginalis, Bacteroides and Fusobacterium. These are opportunistic pathogens. So these are bacteria that you already have, and you have in, relatively low numbers, if you will. They're held in check by other bacteria, lots of it being some lactobacillus that is a main player when we think about normal flora of the vagina. And it keeps most of these other bacteria that still want to live there, but it keeps them kind of in check, all right? So in situations where we can see deviations in the normal flora, some sort of imbalance, it might be like antibiotic therapy, and that can lend to some yeast infections that we'll hit in a second, but it can also lend to overgrowths of different bacteria. Other things that may spur this could be different shifts in hormones that may cause an imbalance, and that in turn sets the stage for an overgrowth of one of these, lending to some problems. Sometimes, maybe many times, it's an asymptomatic situation. You don't recognize really any problems. But then there are potentials for vaginal discharge, burning, odor, and itching that may lend to recognition. So there are some antimicrobials as treatment and a vaginal smear looking for things like clue cells or other deviations, overgrowth of bacteria, lending to diagnosis. So the shakeroid was homophilous, as I mentioned, painful shakers on the genitals, but also dependent upon situations. Mouth or anus could have these lesions. We can see swollen lymph nodes, pus and discharge from those lesions. So all thinking, you know, well, except for the opportunistics at the top, the rest all sexually transmitted. Chlamydia, asymptomatic oftentimes in men, but there could be some symptoms, urethritis, epididymitis, or orchitis in women. Oftentimes there are symptoms with urethritis, vaginal discharge, or bleeding, abnormal bleeding, pelvic inflammatory disease, sapropharyngitis, and there are potentials with this for increased risk of cervical cancer. So definitely more issues as we think about females and the potential for more pronounced symptoms. Doesn't mean that they always are. There can be some asymptomatic carriers with females, just as the same with males. And that sets the stage for the potential to be transmitted a little more readily. And it is definitely a pretty big sexually transmitted infection, even right here in little Pocatello, Idaho. All right, it is a concern. All right, so gonorrhea, Neisseria gonorrhoeae. We saw the image of that, the gram-negative Diplococcus, numerous types of symptoms that we can see. Urethritis, dysuria, penile or vaginal discharge, rectal pain and bleeding. There's the potential for pelvic pain, intramenstrual bleeding. The list goes on and on. Pelvic inflammatory disease, sapropharyngitis, risk of infertility and ectopic pregnancies as we see the infection progressing up into the fallopian tubes. There's the potential for dissemination, arthritis, endocarditis, and meningitis, all some potential culprits with this, not to mention the little kids, as we saw the neonatal ophthalmium as this being a culprit with that. Syphilis, we didn't end with it, but syphilis that we talked about just a second ago, the primary lesions, we see the hard, painless chancre moving to the rash in the secondary phase, and numerous things as some potentials with that as we potentially progress to the tertiary phase. Without treatment, we see all sorts of issues, and as I said, possible fatal occurrences with that. Okay, I keep looking at my watch. I'm like, am I gonna make it through here? Or is the next class, are they gonna get ready to come in like last time? I'm like, just come on in. I know you want to hear this. You know they do. They're probably back there right now just listening like, damn it, I wish I was a microbiologist. I can just feel it. All right. And no, that's not true. Here we've got some herpes. These are virions of herpes simplex virus. Looking at them through a transmission electron microscope, numerous virions all scattered about as we see these. And there are lots of different types of herpes. We've seen a couple already. We've talked about chickenpox as a type 3. We talked about some cold sores as type 1. And now we want to talk about type 2, a culprit when we think about genital herpes. Not that type 1 and type 2 couldn't flip-flop in locations, because they definitely could. Just kind of depends on some circumstances. And it also kind of depends a little bit as far as these lesions appear. So we can see some kind of characteristic lesions on the penis. But as we move to some elsewhere regions, like I'm assuming the groin, we can see that the lesions can be very different appearing and almost sort of pimple-like appearance as we see that. So they may be large and painful or small and overlooked, all right, and maybe painless. I don't know. But if they're overlooked, you probably aren't really recognizing. So human papillomaviruses, there are numerous types of papillomaviruses, and we saw some warts before. Genital warts, another potential, and a handful of papillomaviruses that may set the stage for this. So we could see anal or genital warts, also kind of depends upon situation for this sexual practice, and this potentially sets the stage for cancers, cervical cancer or others. We could see, colon, rectal, or anal cancer. There's also potentials for throat cancers as a result of these human papillomaviruses. So this is what we're looking at under a smear for human papillomavirus, HPV. So we've got two different groups of cells here. Our first ones over here, the smaller ones with the little nuclei, these are normal cells, all right? And then the ones next door, very large, the nuclei gigantic compared to the others. Hyperchromasia is, as we're looking at this, indicative of these cells, and we call them coiliocytes, HPV infected cervical cells. So shorter list, but still a lot of players when we think about some of the virus, because there are numerous ones that may be serving some potentials for cervical cancer, and truly others, as I just mentioned. HPV 16 and 18, there are a few others that may set the stage, but these are the two big ones. And setting the stage for cervical cancer. Pap smears, important to help to recognize this. So direct contact, sexual contact, lending to transmission, and there are some vaccines lending to hopefully driving a wedge in the viral life cycle with these. Something that initially started off for girls, but has progressed to both girls and boys being vaccinated with one of these or both of these. I don't know for sure which it is, but definitely a good idea to ensure that that's in the vaccine schedule. Genital herpes, as I mentioned, type 1 or type 2, we oftentimes think of type 2. These, like many virus, can go dormant, so we can see recurring outbreaks. Just depends on really where we're seeing these. There's also potentials to be asymptomatic, and that sets the stage maybe for some concerns as we think about that asymptomatic situation. So sexually contact or contact with open lesions, that's truly the key, and maybe potentials with these asymptomatic individuals to be non-transmissible. So the papillomas fit right up here with the cervical cancer as well, but we've given it its own special row, but these are culprits for this. The HPV just depends on some of these respective strains. Not all of the papillomaviruses are potential cancer causing, all right? So hence truly some of that separation. So genital warts or other warts, we think about direct contact. And when it comes to things like genital warts, we think sexual contact that lends to transmission with that. Neonatal herpes, also type 1 or type 2, and we see all sorts of potentials in these situations with neonatal herpes as being more of a systemic infection. So vesicles on the skin, mucous membranes, eyes, in disseminated infections, there's all sorts of issues as we think about maybe central nervous system involvement, motor impairment, and maybe death as a result of that. All right, shifting to some fungi to wrap it up, just a couple of images left. So chlamydia is a fungus that we have mentioned kind of repeatedly, and we've talked of it as some possibilities as an opportunistic infection with antimicrobial therapies. Taking broad spectrum antibiotics may set the stage to the chlamydial, the candida. I'm seeing chlamydiospores. The candida to get overgrown and replicate out of control, lending to issues. So as we're here, we're thinking, vaginal infections or yeast infections in this situation, but there can be other opportunities, and we could think of thrush with it in the mouth. And it really just kind of depends on circumstances. There are also possibilities for candida to be systemic and cause other issues. But again, in this chapter, this is really what we're thinking about. So they produce some pseudohyphae in part of their process of replicating. This tube emerges, and it can be something that may also lend to some virulence if it can help to kind of intercalate in between some cells and tether itself. It's not a true hyphae. So here we can see some germ tubes. This pseudohyphae, right, is really what we're thinking about as it is starting to emerge. When the yeast cells replicate, we call them mother cells, and the one budding off from it, the daughter cell, and this mother cell generating this germ tube. It's only 6 minutes old. We're doing some time-lapse photography as we're making some of these images. That's where we're getting that. So I mentioned the lactobacillus a second ago. These gram-positive rods, and this is a squamous epithelial cell, and there's bacteria kind of all about, right? As I mentioned, these big players, all right, making up a lot of the normal flora. And lots of broad spectrum antibiotics may in turn target some of these gram-positive bacteria, dramatically depleting the populations of these organisms and lending to a big overgrowth of the candida that's there just waiting, right, for the perfect opportunity. And wiping out the lactobacillus sets the stage for that. I think there's other potentials with our lactobacillus because they, in their process of doing some fermentations, they create more of an acidic environment, and that becomes inhibitory to other players as well. So not only is it just the fact that they're taking up a lot of the space, out competing things, they're also in their process of just living, create an environment that becomes pretty inhospitable to other things as well. So important to keep the lactobacillus happy. So here we can see some of the Candida albicans in another smear. This is a KOH, or potassium hydroxide prep, that basically, as the potassium hydroxide is applied to the slide, and it's a wet mount, so it's not heat fixed, it's just swabbing, adding a drop of potassium hydroxide, and then slapping it under the microscope. The potassium hydroxide causes the epithelial cells, the keratin in them, to kind of break down, and then it clears them away, and what you're left with are the yeast cells sort of hiding underneath. So here, Trichomonas vaginalis shifting away from fungi to a protist. Trichomonas vaginalis is a protist that only exists in this trophozoite or feeding stage. The flagellate's all you get, all right? Lots of protozoal parasites have both trophozoite and cyst stage, but these guys just this. So transmission is direct contact, sexual contact, lending to infection. Oftentimes with Trichomonas vaginalis, it's the female that exhibits symptoms, and the male almost always tends to be asymptomatic. However, both partners need to be treated to ensure that you've actually dealt with this little organism. Because if she gets treated, but he does not, he will just give it back once she's done with the treatment, right? And that's not a good situation, right? So with the Trichomonas vaginalis, oftentimes, as I said, more symptoms in females, urethritis and discharge, vaginal discharge, but there can be penile discharge in males, can be. But oftentimes it's maybe a little more burning urination that they may experience, not anything that is super pronounced, all right? But I feel like if it burns when you pee, you probably ought to see somebody, right? Probably ought to, all right? So just saying. This, you know, really, there were only two. So they're like, we're going to put the fungus and the protist together and slap them onto this figure. And that's, there we go. That's the end of that. All right. Right on time. 2 minutes to spare. Questions or concerns? All right. Happy Friday. Farewell. Farewell to all of you tuning in at home.